All right, so I think we'll get ready to start. This is the second day of the National Conference on the Prevention of Diabetes, the third edition that we've had. Welcome to Emory University, and we have the first session is on the cardiovascular outcome trials in diabetes. Exciting because finally it feels like diabetologists may also be helping to do something meaningful for folks with diabetes and cardiovascular disease. The first speaker is Dr. Peter Gade from the Southern University of Denmark, and will be joining again back into the Steno Diabetes Center, where he initially did some of the work on the Steno trial that shows us that we need to do a lot of things to help folks with diabetes. Each of the lectures will be about 20 minutes. They may go bang, bang, bang. The first lecture and the last lecture got a lot of the most interesting information. Fair warning.
Okay, thanks a lot.
Dr. Gade.
Thanks. And you can hear me up in the back? Okay. First of all, I have nothing to disclose about this presentation. I'm going to talk about the GLP-1 receptor agonists. And when we talk about that, we hear a lot. This is one of the drugs that we call incretins. So what are the incretins and what is the incretin effect? So let me just briefly take you through that. First of all, if you consider an experiment that was performed a long time ago, back in the 80s, you can see these are 8 patients having a oral glucose tolerance test performed. You can see that is the blue bars here. And on the next day, the very same subjects, they had an IV glucose infusion trying to mimic exactly the same glucose response as was seen in the oral glucose tolerance test. And if you measure the insulin production at the same time, you will see a huge difference whether you give it on an oral or an IV infusion. You can see here we have the black ones. Here we can measure the insulin response. You will see there's a sharp and rising insulin response that will last for about 2 hours until it's back again. But note that if you give the IV infusion, you will see that the insulin response is much, much lesser, even though the glucose values are exactly the same in these 2 patients. And this is, in fact, what we call the incretin effect. There is some kind of messenger that promote an insulin secretion if we ingest something instead of having it orally. One of those hormones is the GLP-1. And as you can see here, here's what happens with GLP-1 during the test. First of all, the glucose, you will see that it goes down over time. But at the same time, you will see that the GLP-1 also goes down to a certain level. Here you can see the insulin production. It will go up in the beginning. Or here again, we have the GLP-1, and you will see the insulin rises. But the important thing is that it only works until a certain amount of time. When the glucose values go of around 5 millimoles per liter, the insulin production will stop. And this is why these drugs don't cause hypoglycemia, because they only work if glucose levels are high. You will see that if you have type 2 diabetes, the incretin effect is much lower than compared to a background population. Here we have it in a control group. You will see there's a very large incretin effect, whereas this is diminished in patients with type 2 diabetes. So in type 2 diabetes, secretion of GLP-1 is low. Beta cell sensitivity to GLP-1 is low, but you can normalize this by giving supraphysiological amounts of GLP-1. So how does a GLP-1 analog actually work? It's a quite interesting hormone because it has lots of different actions in the body. First of all, it goes directly into our brain and tells us that we don't have to eat anymore, that we feel satiated. This has a direct effect on the appetite. It works in the stomach. and it diminishes the gastric emptying, so we will feel that we have eaten for a longer time. It has a direct function in the pancreas. It promotes insulin biosynthesis, and in animal studies, it seems like there is beta cell proliferation when you give a GLP-1 analog, and then it also reduces beta cell apoptosis. It has direct functions in the liver. As you can see here, it increases the insulin secretion and decreases the glucagon secretion, thereby diminishing the glucose production. So you can see here, it acts on many, many different aspects, which we think would be good in patients with type 2 diabetes. Where does it come from? Well, it's being secreted from the gut. As you can see here, in the intestine, we have something called the L cells, and this is where the GLP-1 hormone is being secreted. Now it is being broken down in the body by an enzyme called DPP-4, and by blocking this is how the DPP-4 inhibitors actually work. But of course, you can also give a GLP-1 analog if you want to raise the level of GLP-1 in the body. So what is it with these CVOTs, cardiovascular outcome trials, that we are going to talk about now? First of all, you can see here that during the last years, there's a tremendous amount of studies called CVOT trials. You can see some of the names up here, and you will see that we are here in 2018. There will still be more to come in the years to follow. Now, all these trials are being performed of one reason only, and this is because it's a requirement from the FDA. Some years ago, there was some trouble with the glitazones, and after that incident, the FDA wanted safety trials performed for all new glucose-lowering drugs on the market. Now, these are safety trials, so in reality, they don't have to show that this new drug is better than the drugs already on the market. They have to show that they are less, or that they are not more dangerous than the drugs on the market. And you can see here the word non-inferiority plays a big role in all these trials. They're not non-inferior to the drugs already on the market. They set out a boundary of a hazard ratio of above 1.3. If it is less, the upper confidence interval is less than 1.3, then it is a safe drug that can easily be on the market. If it is above 1.3 or less than 1.8, you need post-marketing trials, and if it is above 1.8, you have to stop the drug, or it won't be registered in the countries. You have to follow patients for at least 2 years on CVD safety data. So again, these are we do two different trials. We do superiority trial or efficacy trials, and we can do safety trials, as you can see here on the right side. So if we go specifically to the GLP-1 receptor agonist, there are 4 trials out there so far. A 5th has been declared superiority, but we will hear about that in the coming years. We have the ELIXA trial examining the effect of lixisenatide, LEADER examining the effect of liraglutide. We have the SUSTAIN-6 trial examining the effect of semaglutide, and then finally exenatide in the EXSCEL trial. So if we go to the first of these trials and we look at the method sections, you can see that this is a safety trial, because you can see here it's a non-inferiority trial. The upper boundary of the confidence interval of less than 1.3 is the primary outcome of this trial. In this trial specifically, they look at a composite endpoint of cardiovascular death, myocardial infarction, stroke, or hospitalization for unstable angina. It's a little different from the original MACE that the FDA actually requires in the trials, but anyway. What happens if you give lixisenatide? Well, you lower glucose. again, remember, this is a safety trial. So the ideal trial is to have exactly the same glucose control to see whether there are problems with the drug itself. If you have a difference in a trial like this, is it due to the differences in glucose or what? So the ideal is that the glucose levels should be exactly the same. If you look at the primary endpoint, the trials, you will see that the two groups are very, very similar to each other, almost on top of it. So there's no significant difference, meaning that it is not worse than the drugs already on the market or the placebo arm, and it is not even better. So this is a safe drug that didn't demonstrate superiority. What about liraglutide, another GLP-1 analog made back in Denmark, where I come from? Again, you will see it's a safety trial when you look at the methods. Once again, we have this margin of 1.3 of the upper confidence interval. And you will see here that the primary endpoint is cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. And this is, in fact, the original MACE that the FDA requires for all these CVOT trials. If we look at the LEADER trial, you can see here that it's a large trial. Almost 10,000 patients are enrolled. They can be enrolled on different inclusion criteria. But the idea is that these patients are high-risk patients. They have already known CVD, or they have a lot of risk factors for CVD. And what happened, if you looked at the primary outcome, you can see here, once again, the primary endpoint is non-inferiority. And as you can see here, liraglutide is lower in incidence than the placebo group. So indeed, there is non-inferiority. You can see here that the upper range is 0.97, so it's way less than 1.3. But on the other hand, this trial also demonstrates superiority. So in fact, liraglutide is better than placebo. So actually, it's more efficient than placebo. Quite interesting, if you look at death from cardiovascular causes, we have a p-value of 0.007. So there's a significant reduction in mortality if you use this GLP-1 analog in patients with type 2 diabetes. If we look a little more detailed into the outcomes of the trial, you will see here in the bottom, nephropathy. When we talk about type 2 diabetes and complications, sometimes we tend to forget that these patients also have microvascular complications in the eyes, in the kidneys, and the nerve. Not everything is cardiovascular disease. So it's nice to know that even nephropathy is reduced by giving this specific GLP-1 analog. And it works even in patients with low kidney function. And that's quite new, even in patients with a GFR of less than 30. Of course, the confidence intervals are wide, but the hazard ratio is below 1. So this is reassuring. Once weekly, semaglutide, we see exactly the same pattern. It's a CVOT, so it's a non-inferiority. It has been designed also to show superiority if it's there. 3,000 patients followed for 104 weeks. Again, the primary endpoint, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And if we look at the glucose values, and if you look at the body weight, you will see that there are huge differences between placebo and semaglutide, and body weight is reduced of around 5 kilos over the duration of the trial. And if we look at the primary endpoint, once again, you will see that there's a difference. The upper confidence interval is 0.95, so it's way below 1.3, so it's safe, but it's also below 1.0, so in fact it's superior to placebo. Again, if we take a further look at the microvascular endpoints, once again, we see here that it is very efficient in preventing diabetic nephropathy. But if you look at retinopathy, you might be surprised to see that this drug, in fact, does not reduce retinopathy. There's an increase of almost 76%. So what are we going to do about this? Who are the ones who actually will progress in retinopathy with semaglutide? This is, of course, an issue that the FDA took up. So did more detailed analysis of retinopathy with semaglutide, and it turned out that the ones actually progressing in diabetic retinopathy were the ones with retinopathy at baseline. Here you can see the ones with retinopathy at baseline, and here are the patients without retinopathy at baseline. And the main reason is the decline in HbA1c once you are put on semaglutide. Here you can see these are the ones without retinopathy at baseline, and here you can see this is the decline in HbA1c, less than 0.5, between 0.5 and 1.5, and above 1.5. And here you can clearly see, even in the placebo group, there's a progression in retinopathy in the ones having a very large decline in HbA1c. So the saying is that semaglutide in itself does not promote retinopathy. It is the size of the decline in HbA1c over the duration of time. And then let's go to exenatide, another GLP-1 receptor analog. Once again, a very, very large trial. Patients are followed up for 3.2 years. And if we look at the primary endpoint, again, that is cardiovascular mortality, it's non-fatal strokes, it's non-fatal myocardial infarction. And you will see here that the upper confidence interval is less than 1.3, so it's safe. But it touches exactly 1.0, meaning that there is a p-value of around 0.05, meaning that it is not significant on the primary endpoint. This is one of these p-values where we really can discuss whether it is significant or not. But anyway, as you can see here, the p-value is 0.06, and if we are very strict, we set it to 0.05. Here again, quite reassuring to see that all the secondary outcomes are less than 1. And even in patients with impaired kidney function, we see that there is no clear signs of this drug being non-safe. And then finally, dulaglutide just presented this press release last week, where you can see that they also claim superiority with their SAVOR trial, the Rewind trial. But of course, this is just a press release. It hasn't been published yet, so we still have to see what goes on. So just to conclude, a number of SAVORs have been published for GLP-1 receptor agonists due to patients rather than due to the will of the pharmaceutical companies. So far, 2 of the 4 trials with a GLP-1 analog have demonstrated superiority with regards to cardiovascular disease. And a 5th trial, as you can see, has claimed that in a press release. But of course, we have to wait to see the publication. And with that, my 20 minutes are up. Thanks a lot for listening, and back to you, Darren.
Thank you. We will hopefully have an opportunity for putting it all together at the end and asking further questions. My name is Darren Olson. I'm an endocrinologist here at the Atlanta VA and with the Emory University. Thank you. I will try to go through a whirlwind of the other drugs, why are we calling it the other drugs? Because they're not the GLP-1 receptor agonists and they're not the SGLT2 inhibitors. I have worked on some of the cardiovascular outcome trials, although I don't have any financial relationships. In general, because I'm going to give you a whirlwind, the punchlines are we're not going to see any additional benefit in the drugs that I'm going to discuss with you. We are going to see a lot of safety, and then we'll bring up some of the considerations that either our older drugs, the thiazolidinediones and or the sulfonylureas, may still have some concern about not being safe. Since there's going to be many more of the drugs discussed, so the first, Dr. Glycated has already discussed the GLP-1 receptor agonists, and there's some concerns about which ones come from human GLP-1 or from exendin-4 analogs, and he's talked about the roles of how they work. DPP-4 inhibitors can also increase the incretins. They also increase glucagon. They also do things directly on other parts of the cardiovascular system and the immune system. And then there's other drugs as well. We're going to briefly talk about the insulin itself, as well as the drugs that decrease intestinal absorption of glucose. Sulfonylureas will increase insulin. Thiazolidinediones should increase insulin sensitivity. And without stepping through too much of the mechanisms of action, the last discussion with Dr. Thomas is going to be about the SGLT2 inhibitors. A similar slide as you just saw from Dr. Gato, taken from the American Diabetes Association, showing you that there are these multiple cardiovascular outcome trials. We're going to focus on some of the other ones. He just went over the GLP-1 receptor agonists, and Dr. Thomas will go over the SGLT2 inhibitor trials. And these are the main trials that we will discuss, either for the DPP-4 inhibitors, thiazolidinediones, the alpha-glucosidase inhibitors, or insulin. Let's start with the DPP-4 inhibitors. Some people call these gliptins. Sitagliptin, saxagliptin, alogliptin, and linagliptin all have data that is now available and have actually contributed to the actual cardiovascular outcome trials. Vildagliptin is not being marketed into the U.S., and so they're not choosing to go, as I understand, into any of the cardiovascular outcome trials because it's only the FDA that's required it, not the other licensing agencies. The first trial we'll go through quickly, the EXAMINE trial, using alogliptin to examine the cardiovascular outcomes with alogliptin, a DPP-4 inhibitor. Similarly large trial, 5,000 patients, folks with type 2 diabetes and have had cardiovascular disease entered into the trial because of an acute coronary syndrome. Similar to the pictures you've already seen of the primary outcomes, the alogliptin showed non-inferiority. In fact, looks very similar to the placebo. Not shown on the trial slides. In these cases, almost all of the trials I'm going to show you had a very small improvement in glycemic control, but always less than an A1C reduction of 0.4, so unlikely to have been clinically significant. And none of the other outcomes that they felt were important came to be superior. All of them were non-inferior for EXAMINE, the first of the trials that came out with the DPP-4 inhibitors. And the next trial came out, the SAVOR-TIMI 53, Saxagliptin assessed for vascular outcomes. And this is also folks with type 2 diabetes, established coronary cardiovascular disease, or high risk for cardiovascular disease, and the primary endpoint being that 3-point MACE, cardiovascular death, MI, or strokes, and completely overlapping over the course of more than 2 years, and subjects also found, so they looked at an extended cardiovascular outcome, still completely the same. So it sounds like, once again, non-inferiority. However, there's more to the story. You may have noticed in the previous slides with the GLP-1 receptor agonist, there was no increase and also no decrease in heart failure problems. Here with the Saxagliptin, if you looked at each element of the secondary endpoints of the extended cardiovascular endpoints, congestive heart failure was increased in the patients with Saxagliptin. People paid more attention back to the EXAMINE study. It turns out the EXAMINE study also had an 18% increase, but it was not statistically significant. So it's possible that there may be some increased heart failure in patients that have the Saxagliptin, maybe Alogliptin, and further analysis showed it was in patients that already had multiple risk factors for congestive heart failure. We won't show that data. The next study is with sitagliptin, the TICOS study, the trial evaluating cardiovascular outcomes with sitagliptin. Again, this is patients with established cardiovascular disease, a much larger trial, a little bit shorter, but also more than 2 years in duration. And the primary MACE, completely overlapping, no difference. Once again, a non-inferiority, safe study. None of the secondary outcomes of importance were different, also non-inferior. And in this case, hospitalization for heart failure was also non-inferior and completely the same to placebo. So maybe there's differences within the category of medications. And the last set of trials are the ones with linagliptin, called Carmelina and Carolina. Carolina, is important because it's also comparing linagliptin to sulfonylureas. This one's chosen to be glimepiride. And they have a large study. The trial started in 2010. Expected end of data collection was this year. We have not had reporting of their outcomes that I know of. And they do have the standard 3-point MACE. They do not have, in the initial pre-specified secondary outcomes, congestive heart failure, but I suspect amendments will have been made given that there's been concerns with the other DPP-4 inhibitors. On the other hand, they also did, instead of a trial comparing to an active comparator, the standard CVOT trial similar to the other DPP-4 inhibitors. Patients with high risk of cardiovascular disease, not established cardiovascular disease. They've now accrued over 7,000 patients, and they have reported just this last month at the European Association of Diabetes that we haven't seen the data outside of the presentation, but there has been a press release, which is necessary in the United States because of investment purposes into the different medications. So of those 7,000 subjects, they have almost all of them with data for more than 2 years. The cardiovascular events were 12.4% in the linagliptin group versus 12.1% in the placebo group. So it's going to be called a non-inferiority study again. There is long-term safety, and there is not an issue with congestive heart failure. And at least the press releases are available online. So the take-home points for the DPP-4 inhibitors, they do not appear to be improving cardiovascular disease risk or outcome, but they are clearly non-inferior, consistently safe across multiple agents. There may be some concern for increase in hospitalization for heart failure, especially in subjects that have already high risk for heart failure, and it may be limited to just certain agents in the DPP-4 inhibitor category. On to insulin. Insulin, as far as the FDA's guidance, was specifically excluded from requiring any cardiovascular outcome trials. So in 2008, when they stated you need on every new medicine to prove cardiovascular safety, they said unless you're insulin, because it's impractical, because it can be considered a life-saving treatment, certainly for folks with type 1 diabetes and many with type 2 diabetes or other forms of diabetes. But newer insulin formulations started to get preliminary data, and meta-analyses or phase 2 and phase 3 studies suggested that maybe there was some benefit. So at least comparative effectiveness trial, which outcomes very similar to the cardiovascular outcome trials has been published for comparing insulin degludec to insulin glargine, one of the newest of the available basal insulins, to what was considered the clinical standard of care basal insulin. Over 7,000 patients, type 2 diabetes, high risk of cardiovascular events, very similar to what we also described for all the cardiovascular outcome trials. And consider as a comparative effectiveness trial, although the degludec had some preliminary data saying it was going to have benefit, it's completely the same as the standard glargine. It also gives us important information that these probably are not increasing cardiovascular disease risk. There was maybe also some benefits to the degludec to reduce severe or nighttime hypoglycemia, but otherwise all of the adverse effects and the ability to tolerate the medications was similar. So insulin safe, thiazolidinediones, kind of the reason we're doing all of these cardiovascular outcome trials. We bring it up because there were already some other safety studies going into place. So there had been a concern for cardiovascular disease risk in a meta-analysis of all the clinical trial data. Kind of an exciting point in time in 2004 in the world of diabetes, people having to change their plans because these were the most commonly used branded diabetes medications. And they had not been shown in high-risk subjects, and they had only been shown in people with suboptimal control. And they have now said, well, what if we look in patients that don't have the known complication of the thiazolidinediones without CHF? So they do have at least some trials, in this case, the RECORD trial with rosiglitazone. This had already been started before the meta-analysis came out, and they similar, almost 5,000 patients. However, they lost a lot of patients during the trial, and there was very low event rates in the trial. So given that, the rosiglitazone was still, if we choose an outcome that is very similar to the cardiovascular outcome trials, very similar 3-point MACE, which would have demonstrated non-inferiority, although it's clearly not below, as all of the other medications we've seen before. There was a concern that there would be increased heart attacks. There wasn't. However, there is consistently increased congestive heart failure with these medications, which is a known issue with them. So that was the preliminary results. They followed up with later results. Now the median follow-up had been out over 4 years, and it still continues to be a non-inferiority result for the primary cardiovascular outcome, but it also still continues to have excess congestive heart failure with rosiglitazone. Pioglitazone, similar data. Also, if we choose this is another trial, the proactive trial, over 5,000 patients, barely getting over a median of 2 years of follow-up, so it kind of matches up to the cardiovascular outcome trials. And it does have, at their longest outcomes, still non-inferiority or potentially a mild improvement in the 3-point cardiovascular MACE, but not set up as were the other cardiovascular outcome trials. So it has a possible mild superiority, but the heart failure, again, was far more in the pioglitazone than in the placebo. There may also be other side effects from these medications. They're not quite the same as the subsequent cardiovascular outcome trial, but they're small or no improvement, and it's been consistent across multiple agents. Rosiglitazone, at least not realistically still available. Pioglitazone, still available, but not considered a preferred agent for cardiovascular disease risk, despite some potential benefits. Those other trials that we talked about, well, one with the thiazolidinediones called the TIDE trial, also looking at vitamin D, stopped, and we really don't have the full data to evaluate because of futility. Kind of sad because this is the largest of all the trials that have been done. The IRIS study, well, it's done, but it's not in folks with diabetes. There is a small reduction in cardiovascular disease with pioglitazone in patients that had strokes or TIAs. Not clear how to put it into the context of the other cardiovascular outcome trials. And the acarbose, the medications that block alpha glucosidase and reduce glucose uptake in the gut, there was no reduction in cardiovascular disease. Another so-called non-inferiority trial, but very selected population, and these were patients with pre-diabetes, not diabetes. So again, not sure how to put it into the context of the other trials. So in summary, I think the same thing we said before. In general, the DPP-4 inhibitors are safe. They have consistent non-inferiority, but no obvious cardiovascular disease benefit and a possible risk of congestive heart failure. Insulin looks like it's safe and necessary for some patients with no additional cardiovascular disease benefit known, only in comparative effectiveness studies. There's not really going to be any further studies on that. Diazolidine-dione's possibly safe, possibly not safe, depending on your evaluation of how your patient's risk for congestive heart failure, and there's moderate or no cardiovascular disease benefit. The glucosidase inhibitors, we don't really have a knowledge in the diabetes population, but it looks to be non-inferior in prediabetes. Sulfonylureas, we're actually going to get some more data, but we don't have any yet. So with that, we'll go actually to the last and potentially certainly more positive data coming out of with Dr. Thomas. Dr. Abraham Thomas, Chief of Medicine at the Bay State Medical Center in Springfield, Massachusetts, and we'll bring up his slides. And he may also be able to put all of the trials into perspective for us.
Okay. Should be that one. Okay. Great, thank you. So look forward to talking about a few more trials in one other area, which is the SGLT2 inhibitors. So I have nothing to disclose. And what I'd like to start off with is we've actually made a lot of progress, even though sometimes we're not always sure that the results that we're getting are ideal. This was a study that was done just a year ago in 2017 that looked at cardiovascular outcomes in patients with type 1 diabetes and matched controls. And what it shows is if we look at death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease, the blue are people with type 1 diabetes, and the red is matched controls. There's still a gap, though actually in type 1 diabetes, this gap is narrowing. And as we get to this time frame in the last, essentially this is 2012 and 2013, which is the last set of years when this was analyzed, some of this gap is actually no longer significant in type 1 diabetes. So we've actually made some progress and impact on death and cardiovascular disease components. If we look at type 2 diabetes, and it's the same pattern, the blue is the type 2 diabetes, the red is the matched controls, and the same outcomes. We do see an improvement in all of these parameters for type 2 diabetes, but there still is a gap. So what this means is in both of type 1 and type 2 diabetic patients, even though we've seen improvement, they don't still have the same lifespan or longevity or freedom from hospitalization as matched controls who don't have diabetes. So the nice thing about going later in any talk or series of talks is other people have already presented the things like how these drugs work. So the SGLT2 inhibitors work by inhibiting glucose reabsorption. And for those of you who may know the background of this story, this was identified by a family or kindred that has a mutation naturally occurring that knocked down the SGLT2 activity. And these people don't get diabetes, and there is no increased risk for cardiovascular events. And someone came up with a bright idea of let's make a drug out of this, and they were able to do this. So the first study that was presented in terms of cardiovascular safety is this EMPA-REG study, which was looking at empagliflozin, their cardiovascular outcomes and mortality. And this study, and I'll show the data, is an amazing study because this was the first study to demonstrate an improvement in hard endpoints such as death for any diabetes drugs. Now, metformin in the UK PDS study had an impression that it was leaning towards a significant impact, but did not reach significant. So this is unique, and this is the first study ever to show an improvement in mortality. So let's look at what this does. So this was a trial And we looked at placebo, empagliflozin at 2 doses, 10 milligrams and 25 milligrams. And you could see over the course of the many years that the study was done, a lowering of the A1C, which was maintained throughout most of the study. Now, when we look at the outcomes, the primary outcome was a composite outcome, as many of these studies are. And one thing I would just say is the reason composite outcomes are done is in each of these trials, they want to list the number of events. And if you did one outcome, you might have to wait a long time for the events to happen, especially as we're taking better care of patients with diabetes because of blood pressure and statins. The events don't happen as quickly, so by having a composite outcome, you get more chances to have events, and actually the trial stops. And these trials are incredibly expensive. We don't know the exact amounts, but based on data from similar trials like ACCORD, to run these cardiovascular safety trials can run $25 to $100 million. So for the companies that are doing them, they want to actually get the data for the FDA as quickly as possible at the lowest cost that's reliable. So the reason I brought this up is a composite endpoint. We assume that if a drug is working in one way, that the composite endpoint reflects an improvement in all of these areas, but we don't know that for sure. We might have an improvement in myocardial infarction, but we might have a worsening stroke. The composite endpoint doesn't always tell us that. And when there are opposite differences, we see sometimes a negative effect. If you look at the primary outcome, empagliflozin versus placebo, there was an improvement, which is significantly different. If you look at death from cardiovascular disease, which is the red, empagliflozin versus placebo, significant improvement. And this is, like I said, the first time we ever saw this, death of any cause, improvement in empagliflozin significantly versus placebo, and also decreased significantly for hospitalization for heart failure. So very exciting because for the first time we have a drug now that actually decreases mortality. So another trial that was done was for Canagliflozin, and it also looked at the same parameters. So let's look at this. Glycated hemoglobin was lower in the Canagliflozin group, which is in blue. Body weight went down. Interestingly enough, body weight went down in placebo as well. Even though nothing special was done, we do see this in clinical trials that when someone's in a trial, they start to do things they normally don't do. So we see body weight going down in other trials as well. It's not unusual. Otherwise, if this was really true, we should just give everyone placebo to lose weight, and that doesn't work. We also see a lowering of systolic blood pressure and a lowering of diastolic blood pressure. And this is a known effect of this class of drugs. So when we look at the cardiovascular outcomes, and this is a composite outcome of cardiovascular causes, non-fatal MI, non-fatal stroke, we also see a significant reduction in terms of events for canagliflozin versus placebo. And so not only is it non-inferior, it is also showing superiority. As Peter had mentioned in his trials, now these trials, because of the impacts of these studies, are looking for both. Versus before, the real goal was just to show non-inferiority. If we look at death from cardiovascular causes, it's not significantly different. If we look at non-fatal stroke, not significantly different. And if we look at non-fatal myocardial infarction, not significantly different. So actually the composite showed a benefit, but if you look at any individual component, you really don't see a significant reduction. However, these confidence intervals are very similar and they overlap the overall composite. So it may be if there were more individual events, these two also would have been significant. But by adding all three of these up together, we actually get this significant result for the composite MACE. What's also interesting is looked at hospitalization for heart failure, which was lower in the non-placebo treated group. If you look at death from any cause, just missed reaching significance. If you look at progression of albuminuria, reduction in albuminuria, and if you look at the composite of renal outcomes, reduction in EGFR, renal replacement therapy, or death from renal causes, a pretty good reduction, which is significant in this composite renal outcome. Interestingly enough, as was mentioned, there are now several trials that are underway looking at the reduction of nephropathy and progression of renal disease overall in these agents because of these original trials. If we look at the effects overall, this is just a plot. Death from cardiovascular disease, which is the composite outcome, is significantly improved. You can see that most of these are not significantly improved, but they all kind of fall in the same way. Hospitalization for heart failure was improved. Death from any cause just missed being significant, and then the renal outcomes all show that canagliflozin is better than placebo. Now, these are the adverse effects, and these are just some that are important to note. One that's really important is in the original study, fractures were highlighted in the registration studies that this might be a risk factor related to some of the impact on bone metabolism. And this was brought up at the FDA review that this needs to be studied further. Infections related to UTIs, infections of male and female genitalia, usually fungal, that's been known. What was concerning is still there, and I'm not sure why that happens, is this increased risk of amputation. We're not sure why this happens, but a significantly higher risk of lower limb amputations in canagliflozin-treated patients versus people who don't have it. And I hate to say it, but in the United States, you can tell when there's an adverse effect for the drug because you can only have to watch television for a little while, and there'll be a lawyer asking for you to call them, right, for a lawsuit. In fact, I think someone called me up who was our neurology chair. He's had a friend of his, and he said, "Do you know anything about this?" And he had seen this on TV, and that's why he called. So, the interesting when you prepare for talks, you get your talk ready, and Shirley, who's been the person trying to coordinate and getting all the talks, she asked for them to be sent in a little earlier. But this study just came out, and so this week. So I just added a few slides because it actually is out in press as opposed to some of the other ones were mentioned where we have the press releases. So this is a study with dapagliflozin and cardiovascular outcomes, so similar design to the other trials. And what they looked at is an interesting change. They originally just had the component MACE outcome, but because of other studies in diabetes drugs that have come out, they added, before any data was looked at, cardiovascular death and hospitalization for heart failure outcome as well. So it wasn't originally one of the pre-specified outcomes, but because nothing had been analyzed, because it didn't impact how they were collecting their data, they felt comfortable that it would be valid to do this. And the steering committee for the study allowed this to happen, and all the monitoring committees. So when we look at this composite outcome for hospitalization and cardiovascular death, significant reduction in dapagliflozin. When we look at the original MACE outcome, we actually don't see a significant reduction for superiority, but it's not inferior. And as with the previous agent, if we look at renal composite outcomes, significant reduction with dapagliflozin versus placebo. And when we look at death from any cause, we do not see a reduction overall, but it's not inferior. So we look at some of these components on this plot. Cardiovascular disease and hospitalization, significantly better. If we look at the renal outcomes, better. And I would say this, that of the three drugs, they have even though they have positive outcomes, they're not all exactly the same. Empagliflozin really is the only one that's shown the mortality improvement. This is just looking at some subgroup analyses to see if there's any specific groups that might improve. This is the total cohort. For the most part, in the heart failure ones, they're pretty consistent, if not, even though not all of them are reaching significance. In the MACE outcome, the overall one was not significant, and I would always say anytime the overall outcome's not significant, even though they do the subgroup analyses, you really shouldn't use them to, they can help you suggest future things, but you shouldn't really take them as evidence-based as what to do for treatment, but nothing really significant here as would be expected. Safety events. So this is really interesting. Diabetic ketoacidosis, which has been seen with this class of agents. No increase in amputation, no increase in fracture. And I think, the other typical things, the infections that are there, we know about that. One interesting thing, which I'm going to be giving a talk on about cancer later on and some of these agents, though there's been a risk signal for bladder cancer and a meta-analysis, which I'll talk later on, In this study, there was actually a reduction in bladder cancer in the treated group versus placebo, which it'll be interesting to see, is this a spurious result, or as we get more experience with these drugs, is it a class effect, or is it a specific agent that might be causing more bladder cancer and some are more protective or not harmful? Finally, as I mentioned, these trials are really expensive to do and they take some time to complete. Are there better ways of looking at new drugs and agents and combinations and data? So one way of looking at it is from databases of claims. And this was the first study, which I'm not going to actually show the results because there's actually been a repeat with a larger group, which I will show, called the CVD Real study. And this is looking at comparative effectiveness of these drugs, specifically for SGLT2. And the way this first study was designed was they go into databases of usage that are reported. Some of these are from like insurers, HMOs, et cetera. And in this study, initially when they did it, they had about 107,000 people, 145,000 people, but these groups are a little smaller just because not everyone's in each of these buckets. Most of them were canagliflozin, less dapagliflozin, and because of when this was done, less patients were on empagliflozin. And this just shows the proportion of how many people were exposed to these drugs over time. Part of this is related to how these were approved as well around the world and in the US. So they repeated this study, which is in a larger database, and actually used different parts of the world. So they had over almost 4 million patients that could have been enrolled in this study, and then they had different criteria of what would be eligibility. They got 249,000 people of SGLT2, and out of the control group who had other glucose-lowering drugs, they did a matching by different factors, or propensity matching, so 1-to-1. And at the end, you have 235,064 people on SGLT2 and a similar number who don't have SGLT inhibitors in their treatment. And this propensity matching, because they really are matching in a variety of factors, should have no differences. And you can see similar age, similar proportion of women, similar history of established cardiovascular disease, et cetera. No differences between the two groups. When they look at all-cause death, they broke it down as a total, but also by the different countries that represented these studies in the database, from Asia, the Middle East and Israel, and to Canada and Australia. Overall, there was a benefit for all-cause death mortality with these agents, really driven by almost all the countries except for Singapore, which has very few patients enrolled, and so maybe their point estimates is not reliable. If you look at hospitalization for heart failure, same thing. Overall favors SGLT2 inhibitors. If you look at a composite of death and heart failure hospitalization, favors SGLT2 inhibitors. And myocardial infarction, when you look at the composite, the total of all of these favors SGLT2 inhibitors. So individual trials may not, but these bands are all pretty similar, really driven by the huge number of patients in Korea that were studied, 336,000, which is the majority of the patients that looked at. Subgroup analyses, looking at if people had a history of prior cardiovascular disease or no prior cardiovascular disease, and in all the composite all-cause death, heart failure, hospitalization, MI, or stroke, though there might be a greater improvement with people who've had a prior CVD. It's not completely easy to see if that's true. In all of these subgroups, there was a benefit for SGLT2 inhibitors. So in summary, this requirement to conduct cardiovascular trials are adding interesting, potentially useful information regarding medication choice, even within the same class of agents. Interestingly enough, the FDA recently met and reviewing of the necessity of these trials or changes, and it is possible that some of these requirements will be changing in the future. There appears to be a benefit from SGLT2 inhibitors in regards to both death and cardiovascular complications, though it's not consistent what that benefit is from one drug to another. And there are serious side effects seen in some of these agents, which we will have to look into further. So thank you.
Remarkably, there's even a few minutes left in the hour, and if there are any questions from the audience, I'm sure that they can be entertained by any of the speakers. Any questions? We do have a question. So the question from the audience, is there any input about, is the GLP-1 receptor benefits and or non-inferiority a class effect? I also wanted to say, it's rare that you see an endocrinologist take a fashion risk and pull it off.
First of all, regarding the GLP-1 analogs, they are clearly not the same. I've specifically said that they are receptor antagonists or agonists. Some of these resembles native GLP-1 very, very closely, whereas others, for example, exenatide is from the saliva from a Gila monster. So clearly the proteins are very, very different. So I don't think that you can speak about a class effect regarding the GLP-1 analogs. And this is also why in the guidelines when we treat diabetes, specifically semaglutide and liraglutide are mentioned as the one that we should choose in those patients.
Any further questions? Dr. Ibrahim? So the question is about the new REWIND trial, the newest of the GLP-1 receptor agonist trials.
No, I know nothing more than you. It's just a press release. As I told you, it was there for financial reasons. So. No, that's true. Yeah, but, well, we'll see. It will come out and we will dissect it together.
And any of the speakers have an additional comments or clarifications?
Well, not to be the only one talking, but I just have to say we've heard a lot of drugs, different drugs, and especially I think that it is important to emphasize that especially the DPP-4, the early DPP-4 inhibitor drugs, they are true safety trials. They run for 2 years, and HbA1c is exactly the same in the two in the placebo group and in the active group. So I think that the reason why they show nothing could be because of the same HbA1c and because they are designed as non-real or true non-inferiority trials. So I don't think that we should call them out just based on that. But clearly the newer trials with the SGLT2 inhibitors and DPP-4, they are more designed like superiority trials, so they long for a longer time of period. But I still think that all the other drugs has a role to play in the treatment of type 2 diabetes, definitely. We shouldn't shift to all the newer drugs right away. The old ones are still out there, and if we want to get HbA1c down, they are still out there.
Right. And I guess the only thing I would add is it's a real interesting question of what we should do. Personally, I still think metformin should be the first drug that we use. But then we really have to look at the cost of these drugs versus the outcome of, for empagliflozin, it's death. There's an improvement. But when we look at the cost of all these agents, as a healthcare system in different parts of the world, what is the best regimen in terms of the outcomes versus the cost it requires to treat people? And I think that's the question that each country or insurer, et cetera, health system will have to grapple with going forward.
Could I just ask a question about the amputations, because it's a bit puzzling. And in fact, all of the SGLT2 inhibitors, they have this black box warning, don't they? Do you think that's fair, or are SGLT2 inhibitors different?
So I think actually because of the dapagliflozin trial that just got released, and I showed you, they didn't have an increase in amputations. Almost all of these events have been with canagliflozin, and the black box warning applies to all of them. I'm not sure that it is true that it's going to be all of them because it seems to be limited to the one agent, but we probably need more data. It's reassuring in the dapagliflozin trial that there wasn't an increase in amputations. But it does make you decide. Think about, just as was asked, talk about the GLP-1 agents, the retinopathy issue. It's not a real retinopathy issue, it's a glucose lowering. If you're going to pick an agent, you might get benefits in some areas, but if you're going to have an increase in undesirable effects like amputation or recently reported with gangrene, Fournier's gangrene or fractures, you may also decide to take one drug over another.
A final question. So a question related to metformin and vitamin B12 absorption. I can rapidly state that, yes, it is a consistent and observable phenomenon. It's been observed even going back, I believe, that must be 20-some years when it was first identified. I don't think there will be a trial to pursue it, but all of the comparative effectiveness trials have included it as an additional finding that they're going to look at. And I don't think it has anything to do with cardiovascular outcome trials according to any of the data. All right. There is no clear guidance on whether to monitor it going forward. Some endocrinologists recommend absolutely monitoring it. Some say don't. We already monitor too many things that we don't have a ability to really affect the outcome. There will likely to be guidelines in the future, but not now.
The good thing is it's easily treatable. If there is a deficiency, you just have to give more. So supplementation works. Yeah.
The one that's on Dr. Gata has.
Peter, can I?
Oh, wait, here it is.
Oh, no, never mind. You took it. Okay, I thought you did. I'm like, I didn't.
All right, we'll proceed to the next session, and the role of the diabetes educator in diabetes prevention. Amy Fischel, diabetes educator and nutritionist from the University of Chicago, and she'll have the...
I'm ready. I'm ready.
Okay, we have it ready.
Yeah, I'm ready. That's fine. Thank you, Dr. Olson. I appreciate it. And then let me just sure I know what I'm doing here. Okay, perfect. All right, great. How's everyone? Good. Because we're slightly in the dark, and I know that there are some folks that are listening online, they can do this at home, I'd love to see everybody stand up. This is lifestyle. So let's stretch a little bit. I don't want you to fall asleep while you're listening to me. You can do a little jumping jacks. I'm just kidding. Okay, wonderful. Thank you for indulging me. Oh gosh. Dr. Ibrahim is trying to get me sucked into a little debate we've been having for several years about diet versus exercise. But so my name is Amy Fischel. I'm a diabetes educator, and it is truly a pleasure to be here today. Again, I'm always grateful for the invitations for these to come to these programs. And certainly, my job is, of course, a workshop. It's not going to be the traditional hands-on workshop that most people are typically used to. but I would love some group participation. I know that that's not necessarily possible for the folks that are listening online, but thank you for listening. So by all means, questions, comments, a limerick while I'm speaking, by all means, I'd love to hear from you, but I'm going to be polling some of you as well, so stay tuned. So you're not going to be able to fall asleep, and now that we have the lights on, there we go. So I do not have any disclosures, but again, this is the information that we're going to be discussing today. So again, by the end of this weekend, all of you are going to be able to wax poetic on the US DPP, but I wanted to just kind of refresh your memories of kind of how all this started. You know, again, July of 1994 is where the US DPP started here. And again, when we look at the study closeout for that DPP, that was in June of 2001. And then there were multiple phases after that included the Diabetes Prevention Program Outcomes Study. So we'll get into that in a little while, but they do have funding through 2020 for the long-term information on the US DPP. And as of the end of October, the year 16 major visit was actually collected. And at the University of Chicago, we are one of the DPP sites. I am not the study coordinator, but again, the endocrinologist that I work with is the PI, and they also have a diabetes educator who is the study coordinator. So again, you will be thinking about these things in your sleep after the end of this weekend, but I just wanted to at least highlight the one piece that we are going to continue to talk about is the weight loss over that year 1, 2, and 3. We're looking at between 5 and 7%, and hence the reason why the recommendations of reducing weight by 5 to 7% came to fruition. Again, Peter talked about this and had this in his presentation last night, but it does beg another look. That certainly when we look at kind of that year 15, again, we are seeing that the percentages are not the same. That, again, not everyone is going to escape diabetes. And then I just want to delve a little bit deeper into the DPPOS information that David Ehrman from the University of Chicago was kind enough to give me. And certainly when we look at after 3 years, after 10 and after 15, again, certainly this was kind of our, at 50, reducing the risk by 58%, but at 15 years, it's reducing the risk by 27%. Now, I don't want that to be seen as a negative, because one thing that we have seen based on the DPPOS is that there were lower A1Cs with fewer medications. Again, I'm also a very strong proponent that lifestyle has a very profound effect. And again, we know that we don't want to always throw medications at everything. So we don't want to necessarily say, oh gosh, lifestyle means nothing. It hasn't reduced the risk by 100%. We still are seeing that people are having some improvements, but less medications. Also, lower blood pressure and lipids with less medications. Again, very, very important pieces. Again, certainly you've heard a lot about cardiovascular. Again, this is what people are dying of. Can we minimize that? Now, what has the DPPOS learned since 1996? We know that it's not inevitable, but it doesn't mean we should stop trying and stop using the lifestyle interventions that are available to us. That we know that just the fact that metformin and lifestyle intervention is going to reduce or delay the development. And we have that information up for 15 years, but again, we're going to be seeing some other information also coming out from the 16-year major visit. That we know that there still is some substantial benefits to doing this. And we also know in the United States, it's all about cost savings. It's all about being cost effective. And we know that by doing this, it is a very cost effective method for these folks. And certainly, if you have some time on your hands, or not, I would strongly encourage, just kind of bookmarking this, because again, you're going to see updates from the DPPOS on their website as well. Now, certainly, as a diabetes educator, I always want to see that diabetes educators are used around the world. So when we look at the prevention initiatives as they stand, not all of them use dietitians or diabetes educators, but a substantial number have utilized educators in the study protocols. And certainly we know that the value of the dietitian, and I'm not going to steal thunder from some future presenters this weekend that will at least talk about the role of the dietitian in prevention. And certainly, again, most of you, if not all of you, are very aware of what the National Diabetes Prevention Program looks like. Now, one thing that we have to look at is that it is very regimented. And I want to be very clear that things that I'm going to be discussing for the next 45 minutes, again, are my opinion as well as the research as it stands. It does not mean that people shouldn't be pursuing some of these things. We have to look at the individuals and organizational needs of how we could incorporate prevention into our organization's missions. So again, and that can be done in a variety of ways, and that's what I'm going to be talking about today. But when we look at the DPP study, this is what they did. So very intensive. You're looking at 16 sessions in the first 6 months. And then during the 6 months, monthly sessions. And I'll get into a little more detail about that as well. Now, certainly, it does include lay and health professional lifestyle coaches. And certainly, I'll just interject a little bit about the University of Chicago and some of our decisions because of that. But again, this particular curriculum is set in stone. You follow it, and you follow this to the T. Now, there are a variety of national diabetes prevention programs across the United States. I'll get into this in a little more detail later, but this just kind of gives you an idea of where some of them are. Now, one thing that I want to at least point out is that this is as of last week, just some information on national DPPs. Now, there are 1,736 current pending or fully recognized programs. I haven't looked at the website recently, so again, there might be one or two more. But the pending and fully is important to understand, and we'll get into that in a little more detail, just the intensiveness of getting to being a fully recognized program. At this point, a little over 175,000 participants, the average weight loss, 4.6%. But the good news in the United States, we're seeing more commercial health plans that are going to be covering prediabetes, as well as state health care plans that are also doing that. One thing that's really important here in the United States is coverage. And again, that's one of the biggest decisions why organizations do not want to go and do something like this, because again, it's very labor intensive. And the return on investment may not be what is expected. And I'll show you a little bit about that as well. Anyone here a pending or fully recognized program? All right, fantastic. Pending or fully? Fantastic. One of our programs is about to get their status. We've run programs in our community for 10 years. Excellent. Excellent. And what type of program is it? So it's the CDC recognized program, and it's done through the YMCA. I was going to say, okay, yeah. Okay, with the YMCA. Okay, and we're going to talk about that. There are 6 major organizations that have received funding through the CDC that has kind of aided in increasing the number of fully recognized programs within this. No, and that's great. No, I'd say again, and I'll talk about that too, but thank you. Yeah, so I said, great, that's wonderful. Now, when we talk about what is required for the implementation, they must agree to the curriculum, as well as the duration and intensity. The intervention must be for a year, and they must follow those minimum requirements. And with the lifestyle change program, they're typically 1-hour sessions. However, many of the national DPP programs that are either pending, most of them are pending, they usually say that it's typically a 2-hour session. You put 8 to 15 adults together in a room. For the most part, they're not going to stop talking. So again, that's great because it's all about support. But again, that is something that organizations do need to understand about the time that is required to invest into having these sessions. Now, there are classroom-based or virtual. Now, I want to at least mention that, of course, the CDC does state that virtual can be done in certain circumstances. However, within the United States, Medicare, which is of course, the governing body of how most things are covered, does not cover virtual education at this point. So again, if somebody is going to be doing a virtual program, it is not a covered benefit. It would be an out-of-pocket cost or free to those individuals.
Why is that? Because it's not considered effective?
Well, it is considered effective, and I'll talk about that as well. Medicare just they decided that they did not want to move forward with coverage with that yet until more people were using the in-person program first. Because again, certainly when they rolled out all of the guidelines previously said, oh yes, of course, virtual, they kind of took that back. Because again, right now it's a little slow going with the number of people that are going through the Medicare DPP at this point. So great question, Peter. Now, again, this is all things that you already know. Again, the goal for these the programs, 5 to 7%, greater than 150 minutes per week, and again, really getting people behavior change. It's all about behavior change. But again, the key is ongoing support. Again, the premise of this entire program is the accountability on an ongoing basis. Now, as I mentioned, again, the CDC did fund 6 national organizations to help implement the diabetes prevention program. Now, fortunately, I know that we have a speaker later today that's going to be talking about the YMCA, so I'm very excited about that as well, but I'd say you can also interject, so that'll be fabulous. Again, we also have another speaker that's talking about diabetes prevention in African Americans, so I'm hoping that they will touch on the Black Women's Health Imperative, and then I will also be discussing the American Association of Diabetes Educators very briefly, because of course that encompasses what I do as a diabetes educator. Now, looking at a recent paper and identifying kind of where are we when we actually do these programs. And so looking at all of the different participants in the organizations between 2012 and 2016, again, looking at, and then kind of then looking at who met the threshold for attending 4 or more classes. Out of these almost 13,000 folks, the participants were attending about 14 sessions. So again, if we were looking at, the 16 in the first 6 months, and then once every month, a minimum of 9 is what they need to be meeting. Most were attending at least 14. Only, under 40% achieved a 5% weight loss goal. Again, with that weekly average of 152 minutes of physical activity, only, a little under 42% met that goal. So again, when we look at what were kind of the takeaways from that is we need these people, their bodies need to be there more often in order to actually see a better weight loss percentage. Now, what does this mean for programs who may not be a recognized program yet or want to implement something like this? It has to be about retention. Now, interestingly enough, having the conversation that I have with our DPP program at U of C, again, it's important to note, and many speakers have already commented on this, is that, clinical trials are not real life. Again, when we think of the clinical trials, and especially the DPP, they were retained by any means necessary. So our previous study coordinator, who was a friend of mine, kind of filled me in that that was their major goal. They had 12 staff members handling all of the subjects that were at the University of Chicago, and no one slipped through the cracks. How many people in this room has the ability to do that on a regular basis? I know I don't. Again, I barely have time to eat breakfast, lunch, or go to the bathroom when I'm in clinic. And so again, I would assume everyone is about the same as me. So that is something that we have to really weigh out, is that we have clinical trial and then we have reality. More. Yeah, I agree with you, Mahmoud. I have to say that, so the question, of course, is, do we need to revisit the 150 minutes of physical activity per week? Absolutely. Again, for those of you in this room, who is familiar with the National Weight Control Registry? Yes? Again, so when we look at those folks who've lost weight, now granted, this has nothing to do with diabetes, but again, everything kind of fits together, is that in order to lose weight, and that's the key to this program, that these folks were doing 60 or more minutes per day. No holidays, no breaks, no weekends, no binge drinking. Again, so that's important that people understand, is that we're underselling what really needs to be done, and that's leading to some failures as well. Yes, have your hand. Yes. No. No, and making them do it, and also, again, having that realistic, that, yes, when we deal with an obese individual, it's very different. I was just up in Toronto on Tuesday and Wednesday for Banting's birthday and World Diabetes Day, but I was talking to an exercise physiologist up there, and he has a program that he has modified for the morbidly obese. Because again, certainly we could say, yes, we need 30 minutes a day. They're lucky they could do a minute. So again, we have to be realistic. But yes. Exactly. No, and that's great. No, and I know Matthew, the exercise physiologist that I met, he works primarily with children, and he's created some really, really interesting methods. So I agree. Abraham, I'm sorry. I was going to say that really not been looked at in diabetes, they've been looked at in metabolic syndrome. And I wouldn't necessarily advise it because it is hard to do. But time-wise, these high-intensity modalities for exercise actually show the same fitness benefit. Yes. Even I think the lowest I've seen is 6 minutes. Yes, yes. I have like 4 7-minute high-intensity workouts on my phone. Yeah. If people could eventually do that, yes. It might be something. The issue is time. There might be some other ways to do it. And there's one that I've seen, which isn't the high-intensity one, but essentially for 2 days in a row, they make people walk the equivalent of a marathon, spin up over time. And they actually see benefits of that for many months later. No, and that's exactly the point, that I think we have to meet the patients where they are. But I think that setting this big goal of 150 minutes, it's so overwhelming, whether it's pediatrics or adults, that we have to kind of slowly ease into this and then give them all these options of how do we deal with different intensities that you could still have the same benefit. So thank you, everybody. Anything else? Comments? Okay. We'll jump ahead with AADE. So again, as I said, the American Association of Diabetes Educators was one of the 6 organizations that received funding. And so what they did is they found 46 different programs within the United States that were education recognition programs. So for those of you that are not familiar with what that is, for diabetes educators, in order to bill for our services for Medicare, we need to be an education recognition program. And that could be done in a variety of ways. So the American Diabetes Association was the first that came out with their education recognition program, Indian Health Services, and now the American Association of Diabetes Educators. So we have to follow these national standards of diabetes self-management education. Now, what AADE did is they tapped into these different sites to implement these programs within these 46 sites in the 17 different states. And so what they also wanted to look at is, well, what is happening in diabetes education right now? You know, what are we doing with prediabetes? And so in a 2015 survey, they wanted to see what was happening. And so a little over 80% of the respondents said, yes, we're working with prediabetes. I mean, it's inevitable. In our diabetes center at the University of Chicago, we get them, we can bill for them, you know, and again, they have to understand that it may be a cost for them, but we are working with prediabetes patients. What we've also were implementing earlier on is having every 4 or 5 months having a free class for these prediabetes folks that our primary care physicians were sending to us, so they didn't have to pay for it, but at least they received some education. Again, what we see from the evidence is that it's just not enough. It's not going to sustain them, and that's the one problem. 80% of, so again, the AADE has their education recognition programs are called DEEPs. They reported having some kind of program. So again, they were using the curriculum from the diabetes prevention program. They were using that information. But less than a percentage, less than 0.5%, reported any reimbursement whatsoever. And unfortunately, when we look at the scope of diabetes programs across the U.S. over the last 10 years, they're closing. I audit diabetes programs as well, and you know, every once in a while, like I usually go out 2 or 3 times a year, and it's inevitable that at least one program that I'm supposed to be auditing closes. And so that's a very disturbing thing to think about, because again, we have so many people that need the services. It's just that they're not getting them for a variety of reasons. Now, this is just the AADE DPP information. You know, so as I said, they started in 2012, and they are continuing. Now, what they did is, as I said, the 46 different programs, they received some funding for that. Now they've opened it up that if anyone wants to use their services, they can pay for an annual subscription, and AADE can help them do so. So again, that's just something to keep in mind as well, but it is a cost. So why is AADE an ideal choice for diabetes educators? Well, in theory, we have a larger pool of eligible participants. You know, again, we are already doing the education as diabetes educators. In theory, the collaboration should be there with primary care physicians. And again, then, if those folks are actually developing diabetes, they have somewhere to go. That's the theory. But again, theory and practice are always 2 different things. We know that as well. Now, they published a paper on the 25 of the sites back in 2016 to assess, have they met the goals of the national DPP. And so what they found is, based on all of the standards for the DPP, is that they met the criteria. Physical activity was not met, but it had more to do with they didn't document it. And as we know, anybody who's done clinical trials, so like as the FDA says, if it's not written down, it didn't happen. So, you know, again, that had more to do with what was happening here. They also found that the weight loss, you know, again, the average weight loss was almost 6%, but again, only 15 of the sites met that criteria. You know, again, the session attendance has always been an issue, and again, 6 of those sites met that criteria. So again, there are options, as I said. There is another one that is available. So for those of you who have not heard of it, Conversation Maps, is, of course, a diabetes program with multiple 3-foot by 5-foot maps that are easy to read and generates a discussion between a small group of folks. Healthy Interactions is the company that created those in conjunction with Lilly outside of the United States and Merck within the United States. They created their own version of diabetes prevention maps. And so they have been going through to gain diabetes prevention recognition since 2015. So they began the application process. And typically what happens is they start the process, and again, for the most part, if you meet all of those requirements, you become fully recognized within a year. However, again, it's very hard to do so. And so, again, they were finding it very difficult to get fully recognized even since last year. So they're still working on that. However, they're in the process of licensing those maps. So in the event that someone is interested, my colleague Julia Saki is happy to entertain any questions from anybody. So again, if anyone's interested, because again, they are lovely maps. Again, it's just that certainly if you have the ability to utilize these, as I mentioned to them, I'd love to see it in children as well. But again, that's just me. And so they also have their own curriculum that they've created. Now, another program that is available and is also funded is for Native American youth. Now, also, we have another talk on Native Americans, so I'm hoping that they'll touch on this as well. Because, again, when I was up in Toronto, I was talking about type 2 diabetes in youth. And for those of you who are aware of the RISE study, that is not very good news when it comes to children. I mean, has people seen the RISE study? Yes, no? So just to give you a brief overview, the RISE study is both adults and pediatrics looking at how do we preserve beta cell function. The bottom line based on that is that children are progressing much faster than adults. And also that even looking at when they're on medication, it doesn't seem to help. So one thing that we have to understand about that is we need to get to these kids much sooner. Because again, if we're dealing with a 10, 11, 12-year-old, they're going to have complications before their frontal lobes actually, mature. So again, we need to do something to keep these kids safe. But again, the Native American, this is just a wonderful program. They've had this going on since 2003. They just received, back in 2017, a new grant cycle. So they're able to roll this out through 2022. And again, it has a lovely curriculum that is available. Again, this is the map of the different sites that are using this. And it is kind of an invited type of thing that, again, you have to be invited to do this within the Native American, the different locations. But again, it's wonderful to see that it is representing, with the exception of a lot of the Midwest over here, again, we're seeing a larger number throughout the United States. And I know that even Canada has something very similar as well that's going on. Now, any questions? Any insights? Anybody ever see any of these different programs? Okay, fabulous. The Native American one? Fabulous. Have you seen it in action? Okay, I'd say I'm looking forward to hearing more about that as well. Now, as I mentioned, that when you look at the state of the recognized diabetes programs, diabetes prevention programs, there aren't a lot because, again, it's a very long process unless you have funding to be able to do that and the bodies to kind of help you to kind of implement it. Like I said, please make no mistake, I am not saying that the prevention programs are not valuable. I'm just saying that it's very important that before people jump in, that they kind of understand the full scope, but also understand that there could be reciprocal, options available so you don't have to go through all of this as well. However, there are many diabetes centers that do not have the recognition, and at the University of Chicago, we have decided not to at this point. And the main reason is that we're in the middle of Chicago. There are 25 to 30 different prevention sites that are trying to attain full recognition. So at least we do have options to send our patients to in the event that they want to be part of it, and we want them to be part of that. The problem is that if there is a diabetes program that is in the middle of nowhere, that's where I think that we should be seeing some more implementation there. And a lot of reasons when you ask diabetes centers why they are not going to be recognized is that staff, again, it costs a lot to have, the staff to do this. They don't have the space. There's too many in the areas, and of course the budget. Again, I'm always gently arguing with my boss to try and get more money for a variety of things, but again, I would rather that I'm dealing with the 10 to 15,000 patients that we're seeing for diabetes and have an extra educator for that than holding some of the classes, because again, when we look at reimbursement models, that I'll show you. But one thing that I also want to mention is that registered dietitians do have the ability to bill for services, not pre-diabetes, but for obesity. And so again, that is important that if there are dietitians that want to do medical nutrition therapy, again, it is likely that they can. Now, we have a weight management program within our entire diabetes program as well, and 95% of the obesity patients that are being seen, it's a covered benefit on their commercial insurances. So again, I do strongly encourage that if a dietitian is going to be seeing some of these folks, making sure that those individuals check their insurance for these CPT codes. So the 97802, 97803, individual versus group versus initial versus follow-up. So again, this is an option that most people aren't even tapping because insurance companies aren't going to tell us what's covered unless, unless absolutely necessary. Now, online. So again, there are several studies that are being done looking at the value of online. We know that there's a benefit, but as I said, Medicare does not cover it at this point. However, the study was held within the VA system, and so they wanted to compare their online program to their in-person versus their weight loss program called MOVE. And so what they did, and now granted 158 participants, far more than a lot of studies, so again, I thought that was very nice, and they completed at least 8 or more of the modules. Their mean weight change was almost 5 kilograms at 6 months and 4 at 12, so quite impressive. 87% completed the online program versus 59 in person versus 55% for the weight loss program. There was no significant weight difference between the in-person versus online, but this is where, as, in the United States, kind of storming the hill and saying we need to have these covered because, again, we need to find other ways to meet the needs. Because, again, when you saw the numbers of patients that were being seen in the DPP, 175,000, that's child's play. Again, we need more bodies to have access to this information. Now, there are also, if there are very motivated individuals that want to pay out of pocket for a diabetes prevention program, there are options. So here in the U.S., OMADA and NUM are 2 diabetes prevention programs. OMADA, there are some health plans that do have it. Otherwise, they have to pay about $100 a month to pay out of pocket. NUM is about $59 per month. As I said, if somebody's really motivated, again, you get rid of your Starbucks every day and you can afford this. So there are ways to actually do this. Sweech is also another company that is for diabetes prevention as well. It is, at this point, only available through certain organizations. So when I did talk to both Omada and Sweech, they were reluctant to give me any other information as to who is covering these. So I just recommend that that employees, check with their organization, because again, we're seeing that this is again a program that is global. So, because I'd say the gentleman I was talking to was in New Zealand. So again, I know that this is available everywhere. Now, looking at how to get recognition. So again, we have a few things that have to be done. Of course, it's free. You have to be an organization. And this has just changed. So reports have to be submitted via EXSCEL every 6 months. It used to be at the 1 year. But again, it is something that people have to understand, that it's more information now than anything. And then at the end of that 24 months, if everything is met, then full recognition. So just to kind of put that into perspective. So what is it that you need to know? So again, for the 2 folks that are here that are recognized, for everyone else, and anyone else listening, find out what's available in your area. Again, I have to say that that's very important. And certainly, there was just an article published that when we look at the major fully recognized programs, Philadelphia, DC, and New York have some fully recognized programs, but their fully recognized programs are almost 100 miles outside of the cities. So again, it's just important to understand that, again, it does require a lot to get these programs fully funded. Yes? Yep. Okay. Okay. The other way to do it is that Emory pays the people to do it, and they are doing it already, and they choose certain communities in the Atlanta metro area, and they're growing as they train people. The pay is not exactly what the pay is to the nurses, but I was expecting more. That long commitment. Yes. Okay. Great. Good. I'm very happy to hear that, but it's not fully recognized at this point. I know I'll have to double check the website again, because I know when I was looking at coming here, I wanted to look at Atlanta, and I didn't see any. Yeah, I'd say that was the yes.
So last year's meeting, I think it was Bill Harmon brought up an issue. So he was trying to get their program in Michigan to cover the employees. And what was happening was the employees, they did a lot of things to get employees, but when employees actually came to the program, if the people in the program felt that they may not complete it, they were actually not enrolling them. Yes. Because the requirement for Medicare reimbursement is yes. A certain percentage have to complete. Yes. But to me, I understand you have to do something to show your program's working. Right. But if we're really strict about that, then we actually won't allow people into the program to benefit. And that is, and so again, certainly that is the quandary that, when we think of
the grueling nature of obtaining Medicare recognition, it requires such strict guidelines, and the people that really need it are slipping through the cracks. Because again, you're saying, oh, well, then you can't stay because you're not going to meet what the requirements in order for us to get recognized. Okay. Okay, yeah, because I'd say they are, yes, they're getting, I mean, because it certainly is, yes.
Quick update. No, the Emory program is not a DPP program.
Okay, that's what I thought.
However, there are in Atlanta DPP recognized programs at several of the YMCA's.
And yes.
And full of local medical.
Thank you, I appreciate that. Any other comments? Okay, great, thank you, yes. So in the original guidelines, the Medicare allowed certain components, as long as the weight part was not part of it, that you could do virtual modules for those parts of the classes. Those are not part of being reimbursed at this point. Well, and those aren't really virtual programs. Those are just, standalone programs. There are a handful of programs that have virtual components, but again, it doesn't matter because it's not billed. No, none of the programs can be completely virtual. Not at this moment, because again, when we look at the DPP as it stands, it was all in person, and based on even that one study that I showed you, they're going to need a lot more to validate the benefit of more virtual programs. So again, I have to say that it would behoove us when we look at the immensity of the United States, and of course outside of this country. Again, people cannot get to programs. People cannot, they don't have the funding. They don't have the means to get somewhere. They may live 2.5 hours away from the largest city or a largest program. So we do need to change with the times. And I know that while Medicare has it in their guidelines, time will tell how long that's going to take to actually start implementing something like that. Yes, Mahmoud?
Even for the virtual programs, if they are self-paid, still much cheaper than the physical program.
Well, absolutely. But again, it still does come down to when we think about creating a program within whatever organization, there's still a lot involved. There's still a lot of money involved to make this work. Certainly, again, when we think of the staff needs, even just to get something like even a virtual program off the ground, again, while they're saying, about a half of an FTE for the programs as it stands, that's not possible. You need 2 to 3, at least the equivalent to about 1.5 FTEs, because again, no one person is going to be able to run this whole thing for the duration of the program. Again, certainly also the logistics of becoming a lifestyle coach. Again, the cost of becoming a lifestyle coach sometimes is prohibitive. Again, when we think of marketing and referrals, again, the funny joke about diabetes centers, we'll build it and they'll come. That doesn't happen. Again, in order to find the participants, and as we said that, again, we want to make sure that this is inclusive, but in order to get recognition, you need some very strict guidelines. You need these folks to meet or surpass a 5% weight loss. And if they can't, again, you're going to be waiting to get your recognition. Yes? Yes.
And in the real world, if you're out there with patients, choosing your patients carefully, I would offer that there's an opportunity for new studies to be done for virtual, because why are so many people morbidly obese anyways? Because they're not getting the exercise they need. So perhaps this is time to create a trial where you do virtual and not so much choose your patients carefully and revisit your outcomes.
No, and I agree with you. That might have been me that said that, because I know the Oak Park DPP, they're the ones that kind of were that I kind of gave some information about. But it is that is the sad reality, is that we shouldn't have to choose our patients carefully. But again, we are seeing that reality. I mean, certainly funding. As I said, having an issue. I mean, a lot of the AADE programs, the Y, again, they're getting funding to be able to make this happen. Again, other organizations, you have to fight tooth and nail for everything that you have, and so that's going to be a problem. Again, the retention, making sure that these folks are the right ones to stay in, that they're going to be motivated, and then also looking at kind of timing of classes, as well as who and how are they going to meet the outcomes tracking that is needed, because that is a job in and of itself. Now, this is the update to the standards and operating procedures, which has everything essentially that you need if you say, is this something that our organization can actually do? Because it basically goes through all of the questions of, again, can we meet the needs of everything that we're supposed to do for the CDC? And the same here. So again, definitely it's a very nice, easy way. If you're seeing a lot of no's, it's not something that's going to be a benefit for you. And also, as I mentioned earlier, again, the website does have a registry of all the recognized organizations. And so again, you're going to see if they are pending or full. So again, you can see all of that on that website as well. Now, for diabetes programs, the program coordinator or quality coordinator is what it's called now. Again, has to already do that for recognition, but they are going to then have to do it for prevention. And certainly for those that have seen diabetes programs, that takes a significant amount of time to meet those standards. And then could be a full-time job to handle both. And as I said, the lifestyle coaches, again, they're the ones, and certainly the question that we have to ask is, do diabetes educators need to be the ones that are doing it? And most organizations find that the return on investment may not be what it should be. And so again, looking to lay health educators to become the lifestyle coaches. And certainly you can have a program to become a lifestyle coach here at Emory. So this is also on the website for the CDC. So if you wanted to take a look at some others. Additional resources that are available for recruiting and retaining participants are also available on the CDC website. The CDC, all of their websites are fabulous when it comes to what you need to actually do this program. And the question, of course, is, do I need to become a recognized program, or can I utilize the information to morph it into what I have in my current organization? And that is the question that people have to ask. This is the newest website that they have available, and it's the Customer Service Center. And there's Ann Albright. She's a lovely lady. But again, also, so everything is there for you to take a look at, all of the documents, all of the resources, everything that you need, as well as some just additional information from various programs. Now, of course, as I said, coming from pending to full recognition, again, how do you become full? The minimum of 9 in that session attendance within the first 6 months. Documentation of body weight at greater than 80% of the sessions. Physical activity at greater than 60% of the sessions. Weight loss at 6 months, a minimum of 5%. Then during 7 and 12, a minimum of 3 sessions that they have to attend. Weight loss of a minimum 5%. And this is what kind of holds people up. Most of the programs that are trying to attain full recognition, as I said, again, depending on the location. So again, if you go to Texas and you go to Houston, a large Asian population, again, their weight loss is going to be vastly different than if you're coming to the south side of Chicago and looking at African Americans. And so again, at least in the Chicagoland area, they're focusing on the fluffier African Americans to meet in the program, so they would at least achieve the 5% weight loss. Yes, Jennifer. Not within the DPP. No. Now, again, within the DPP and the DPP-OS, of course, they were looking at A1C, but the DPP program, when it comes to just the lifestyle intervention, we're not looking at that. We're not looking at that because, again, within getting Medicare recognized, all we're looking at is weight loss and number. So again, basically, is are you meeting these? You know, and of course, when it comes to eligibility, they just need to, you know, do they meet the criteria for prediabetes? But not are we looking at ongoing A1C. Now, certainly, most of the programs are doing that anyway. But again, it's not something that has to be done for the CDC. Yes, ma'am.
I think part of the issue that I kind of had with the program is because we had several participants who A1C declined, but the CDC, as far as reporting data, they don't care about A1C. They only look at weight.
Exactly. And something that I do, that's an excellent point that I think that at least for organizations, you know, again, really it's all about bottom line, you know, whether somebody's going to get money or not. So an organization that says, you know what, this person's A1C was 5.6 and they went down to, you know, 4.8, you know, and while they may not have met the requirements for the weight change, you know, again, the organization might say, you know what, we have just saved our organization X number of dollars just by doing that, so we'll keep the program. Doesn't matter whether it's a full recognition or not. So that is something that, you know, again, I think that it behooves us to look at other things. It's just that with the DPP, we don't. Yes, ma'am. Yep.
So the second year they got a little more reasonable.
Yeah.
But we find in the statistics that the more people attend the classes, the higher the weight loss is maintained.
Exactly.
And there's certainly in the outcome study
Yeah.
with that 58% reduction in those under 60, 71% over 60. Certainly after 10 years in the outcome study, you still have the layer onset of diabetes. And then 15 years still.
Yes.
Not as high as in the beginning. But it really is, I just encourage you all as you're looking at this, that it becomes a decision for your organization.
Yeah.
Am I prepared to operate positively as
Yeah.
a net loss?
No.
To say the 0.5 ACE is quite a running good.
Oh, no, that's exactly. And are we going to be hearing you speak later? Are you going to speak? Fabulous. I'd say, I know I was already talking you up, so I'd say wonderful. But no, thank you for your comments. Because, again, yes, and it is something that, you know, that the practical considerations of this, you know, again, we need to, raise awareness. And certainly, politically, I don't want to get on my soapbox, but, you know, I mean, certainly I want to, like, rush the hill and say we need to find a way that this has to be available to everyone. You know, but, again, there's just not the funds to do it. Becoming a lifestyle coach, you know, again, it's important that people understand the cost that's involved with that. Again, really looking at what other programs that are in the area and collaborating, you know, because, again, I have to say, working as a diabetes educator for the last 22 years, this should never be an us against them. You know, again, I want to make sure that every diabetes program that I have within the Chicagoland area, it's like, you tell me what you need from me. I'm happy to send people. Let's work together, because it really should come down to, it's about the patient. You know, I mean, I wish that, you know, we just make sure that we're finding some way, and if we can kind of cut some things out of our budget, great. Was no, and that's, I would love to, you know, I'd say that's something that the organization of, you know, how do you make that happen? And philanthropy makes the world go round, but I'd say certainly trying to find that, it's not happening all in many places. So looking at pros and cons, you know, so looking at various programs that are trying to attain full recognition. You know, there are a lot of time issues, you know, again, and it requires a lot of bodies to make this happen. And we really can't rely on primary care physicians. And again, that is not a diss in any way, shape, or form. They're busy. They're dealing with 10 other comorbidities. It's not about, you know, that this is not going to be top of mind. So we have to find ways to recruit more effectively. Now, so the Medicare billing, this is just kind of the requirements of what needs to be done. And then also for the continuance of services, I'm not going to belabor this. This is something that you can read at your leisure. But also, there has been an update to the payment rates, and I just want to point out what that means. So again, this getting to the point of, you know, initially when this was rolled out and began in April, you know, we're talking, you know, $25 a session. It's increased to $26. You know, 50 increased to 51. 90 increased to 93. So again, when we look at, for those who aren't going to get a required minimum weight loss, you're going to get only $200 reimbursement for that patient. If they did all, you know, jump through every hoop, then we might see about a $690 reimbursement. So that is something that I just need to mention. You know, again, also within the standards, just gives you a nice kind of overview of what you need to do. This I strongly encourage, whether you are a Medicare Diabetes Prevention Program or not, signing up for these listserv updates. Because again, they really do give you a kind of the boots on the ground of everything that's happening, so that you kind of stay and you have your finger on the pulse of what's going on. Because so much happens within our government. But again, this is a great resource. Also, additional tools and resources that are available within that standard, the operating procedures. Again, you have a multitude of options that are available that are already done. You know, again, don't reinvent the wheel. It's not necessary. And yeah, again, these are things that you've already seen, but again, making sure that the primary care physicians are kind of gently throwing these out at folks. If somebody wants to complete, that's the online application site. Some additional resources that are available for everything. And, you know, certainly, as I said, I'm not going to get on my soapbox about funding and our government, but, you know, again, certainly we need to look at what can we do for our patients. How can we collaborate with other programs across the country within our own communities? Because again, that's going to be the most important way to be able to meet these needs. But also don't forget about the fact that there are other options if somebody's motivated enough to pay for them. But with that, I want to thank you so much for your interaction, for your attention, and have a marvelous rest of the day. Any other comments or anything, or a nice good joke? We could use one. It's break, yeah. Oh, sure. Was my email up there? Oh, okay. Well, that's even better. Hold on, let me find it. Well, I'll just tell you it. It's AMY.F as in Frank, I, S as in Sam, CHL, at uchospitals.edu. And I'm always so interested in hearing about other programs, what's working for you. So by all means, I'd love to hear from you. Even if you wanted to rant, I'm fine with that too. Thank you.
I'll announce that there is a break until 11:30, at which time we'll reconvene here for the lectures by Dr. Ibrahim. And
Two.
So that the green button will tell you will give you the pointer.
This is the pointer.
The arrows will move the slides, and the black
This is
button-
forward.
Yep, and the black button at the bottom actually turns the screen on.
Okay.
Hit escape.
Where is escape?